Hello. So Vanessa and I did our journal club on the effects of statins on thrombosis within patients who have COVID-19 and were admitted to the ICU. So let's talk about some previous studies that are relevant to this journal club. So in previous COVID-19 studies, statins have been shown to reduce plasminogen activator inhibitor 1 platelet aggregation and the risk of vascular events such as venous thromboembolism. Statins might also interfere with viral entry through the disruption of the membrane lipid rafts. So why did they do this study in the first place? So this study was conducted to test if a patient in the ICU who had contracted COVID-19 would gain any kind of beneficial treatment effects from statin drugs by reducing the risk of having a thrombotic event or death related to worsening inflammation or respiratory status. So how was this study funded? The study was funded by the Regi Cardiovascular Medical and Research Center. Some of the authors, including the senior author, are affiliated with this research center. Atorvastatin and matching placebo were provided by Sopan Dalro, which is not amount the study sponsors. Neither the funder nor the company who donated the study drugs had any role in the design and conduct of the study, collection, management, analysis, and interpretation of the data, preparation, review, or approval of manuscript, or the decision to submit the manuscript for publication. And these are all of the authors that were affiliated with this study. So what kind of trials were used with this study? A multi-centered randomized control trial with a 2x2 factorial design are what they used. So the hypothesis, it was hypothesized that statin treatment might be of benefit to adults with COVID-19 who were admitted to the ICU. And this is by reducing the risk of thrombotic events or death related to worsening inflammation or respiratory status. So the primary outcome was a composite of venous or arterial thrombosis, treatment with extracorporeal membrane oxygenation, or a cause mortality within 30 days from randomization. Second outcome included the individual components of the primary outcome: venous thromboembolism, arterial thrombosis, and all-cause mortality, and ventilator-free days. The difference between total number of days alive post-enrollment to the total number of days receiving invasive mechanical ventilation.
Alrighty, so now we're going to talk about the inclusion criteria. So they included patients who were 18 years or older with reverse transcription RT-PCR confirmed COVID-19, patients who were admitted to the ICU within 7 days of initial hospitalization, patients who did not have another firm indication for anticoagulation, and patients who were not enrolled in another blinded randomized controlled trial and they were willing to participate in the study. Patients who had an estimated survival of at least 24 hours were also included in this trial as well. Alrighty, so now we're going to look at the exclusion criteria. So there were actually two randomizations. The first randomization was more specifically on the effects of intermediate dose versus standard dose prophylactic anticoagulation among patients with COVID-19. And then the second randomization, which is the trial that we are more focused on, is the statin therapy versus placebo treatment. So a large sample of the statin therapy versus placebo treatment is from the first randomization, which is the anticoagulation study. So the bullet points with the arrows next to them are specific to the statin therapy versus placebo criteria, whereas like the other bullet points are more specific on the anticoagulation study. So they excluded patients who had a baseline liver function test of greater than 5 times upper normal limit, patients who had active liver disease, routine use of statins, previous documented statin intolerance, total creatinine kinase of more than 500, estimated survival was less than 24 hours, and if their weight was less than 40 kilograms. So basically they excluded these patients because these factors wouldn't really be advantageous to this trial. They also excluded patients that were already on statin therapy treatment, so it wouldn't really be effective towards this trial. Alrighty, so now we're going to look at the intervention or experimental design. So the study intervention was a double-blinded assignment to atorvastatin 20 milligrams once daily compared with matching placebo, and this treatment was done in a 1-to-1 ratio. A centralized computer-based system with a block size of 4 was used for randomization, and the site clinicians who basically enrolled the patients received a unique trial registration number for each randomized patient, and the allocation sequence was also concealed from the site clinicians, which kind of reduces a lot of bias. The plan was for the study drug to be continued for 30 days from randomization, or just until the primary outcome was reached within the first 30 days. Now we're going to talk about the outcome measures. So the primary outcome was performed through generalized linear mixed models, accounting for the enrolling site as a random effect, the assigned treatment as the exposure variable, and the odds ratio was reported as the mean effect measure. So venous arterial thrombotic events were diagnosed based on the treating clinician's suspicions, and appropriate imaging tests were done based on the clinician's perception of if the patient had a VTE or not. So the VTE appropriate imagings that were used were the venous Doppler ultrasound, the CT venography, the MRI and contrast venography, and many more. The bleeding complications were assessed according to the BARC criteria, and this was more focused on the secondary outcomes. The proportionality assumption was tested by the Schoenfeld residuals, which did not indicate violation of the assumption, and they also reported a time to event, which was shown with the Kaplan-Meier curves. Risk ratio was also reported within this trial. Now we're going to look at the statistical analysis. So, like I previously mentioned, there were 2 randomizations that occurred. The anticoagulation study was called Inspiration, whereas the statin therapy versus placebo randomization was called the Inspiration S. So, looking at the actual pooled event rate of 44.8% for the primary outcome in the Inspiration study, a sample of 596 patients was estimated to provide 80% power to detect a significant difference for the primary outcome between statin treatment and placebo. So the target sample size for the Inspiration S was increased to 626 to account for an inclusion rate of 5%, and the enrollment was actually terminated due to lack of funding, so only 605 patients were enrolled and only 587 patients were actually entered in the primary analysis. So basically the enrollment stopped before the target sample size was even reached. Now we're going to talk about the enrollment. So 587 patients were entered in the pre-specified primary analysis population, and there were 290 patients who were assigned to atorvastatin, while 297 patients were assigned to the placebo group. Now we're going to look at the baseline characteristics of this trial. So the median age was 57 years old. There were 256 patients that were women, and the median duration of use for the atorvastatin group was 21 days, while the placebo group was 19 days. So overall, the treatment and the control group were relatively similar to one another. However, there was a significant difference between both groups. There was an imbalance between the two groups for the current smokers and the white blood cell count, and they reported that there was a p-value of less than 0.05. There was also a difference between the D-dimer levels, and a p-value of less than 0.15 was reported for that. Moving along, we're going to look at the study findings or efficacy outcomes. So the primary efficacy outcome occurred in 95 patients that were assigned to atorvastatin and 108 patients that were assigned to the placebo group. So it was reported that there was an odds ratio of 84% with a 95% confidence interval. There was also a calculated risk difference of 3.6%. And the results for the primary outcome were largely driven by all-cause mortality. So there were 90 deaths that occurred in the atorvastatin group and 103 that occurred in the placebo group. So there were two-sided tests that were used, and the statistical significance was set at 0.05. There were also consistent findings within most subgroups and insensitivity analysis. And so based on these findings, it was concluded that there was not a significantly reduced odds of the primary outcome between the atorvastatin and the placebo group. Alrighty, so this is just a visual depiction of what I just mentioned previously about the study findings. So you can tell that the placebo and the atorvastatin group are not relatively different from each other, and there was also a hazard ratio that was reported with a percentage of 84%. So now I'm going to mention some of the adverse events that occurred in this trial. So if the patient had a venous thrombotic event, an MI, severe thrombocytopenia, major bleeding, stroke, LFT abnormalities, myopathy, renal replacement therapy, ECMO, or death.
So from this study, the authors concluded that patients who contracted COVID-19 and were admitted to the ICU, atorvastatin 20 milligrams daily compared with a placebo was not associated with a significant reduction in the composite of venous or arterial thrombosis treatment with the extracorporeal membrane oxygenation or all-cause mortality, the effect of a more potent statin regimen, or the impact on a more targeted population of patients with COVID-19 requires additional investigation.
Lastly, I'm going to talk about the reflection of this trial. So there were strengths and weaknesses of this trial, the strengths being that there was a p-value, risk ratio, confidence interval, other statistical tests or statistics and parameters that were reported, which tells you a lot of precision of the data. There was also the sample size, which was a strength of the trial as well. The trial design, it being double-blinded, helped reduce a lot of the risk of bias. There was also a committee that was blinded to treatment assignment, which examined all clinical outcomes, and so this enhances a lot of the reliability of the reported outcomes as well. For the weaknesses, there was possible undiagnosed venous or arterial thrombotic events, and this is because that the diagnoses were based on the clinician's suspicion. So the appropriate imaging test would only be considered based on the clinician's suspicion. And so this is some potential weakness due to clinicians' different interpretation or perception of a VTE. There was also a possible type 2 error, and this is because the enrollment stopped before the target sample was reached.
So this basically concludes our journal club. Here is our reference slides with all the references we use. Thank you for listening.